Okay, so it's 8 o'clock. We are starting. Assalamu alaikum and good evening. This is Dr. Mohammed Kurdi. I'm the president of the Saudi Arabian Vascular Interventional Society. It gives me a great pleasure today to start the first webinar of what we call GIS education series, which is a series of educational webinars designed to discuss some of the most interesting topics in interventional cardiology. I would like to thank the GIS board and this great work headed by Dr. Fawaz Al-Mutari and Dr. Professor Abdullah Chab and his team. I would like also to thank Medtronic Middle East for helping and supporting the program. In addition, I would like to thank ICOM for the great support by hosting such an event. Today we have a very interesting topic. Today we're going to talk about one of the things that we like always to talk about, which is the left main intervention. Left main intervention is an interesting topic because it was really forbidden to touch the left main when we are really very young, and looking at our professors not able to touch the left mains, being forbidden because it's a surgical disease. As years passed, in the last 10 to 13 years, we have learned that no, left main is also an interventional area that we should be more courageous to touch and do, and maybe even in a certain subset of patients, better outcome than with the main area is still a great area for learning. We actually learn and we try to understand what's the best, and how we understand the left main, how we image the left main, what's the best technique, indications, and so on and so forth. So this is why we are starting this educational series with left main session. Give me a great day. Our speaker and our panelists. Our speaker today is Professor Stefan Carler, who's professor of interventional cardiology. Stefan is well and has a great interest in imaging, and in this respect today, he will share with us an interesting presentation about the importance of coronary imaging in guiding stenting. In addition to that, they have a distinguished panelist with me. I have Professor Mohammed Al-Mutari. He's the immediate past president of the GIS, senior interventional cardiology from heart, and Mohammed is well known in the region and the Gulf area with great contribution, and I'm sure that he will, with great knowledge and expertise. We have as well Dr. Muhammad Qutb, who comes from King Abdulaziz University, the cities in Saudi Arabia. King Abdulaziz is the chairman of the Department of Medicine. He's also an interventional cardiology that also gonna add to our knowledge today by his also knowledge and expertise. Today we have an interesting program. So we'll start by the first presentation by Dr. Stefan, which is titled by the importance of coronary imaging to guide left main. Stefan.
Thank you for this very kind introduction. I will start sharing my screen, wishing that all is going through. I am very glad to be again with you in Saudi Arabia via Zoom. I must say that more than 10 years ago, I visited Riyadh for the first time. I was at King Fahd Medical Center, invited by Sami Lawan to actually start an IVUS core lab there and to do some interesting studies. And I've been there a couple of times after for some CTO meeting that is now going on for now a couple of years. I'm sorry, I have to stay in this country now where it's only 20 degrees and without any further introduction, I wanted to give you some colored recent updates on left main disease, colored by my side of always looking from inside and addressing finally those kind of intervention, stressing on the importance of imaging. But I was asked to finally answer these couple of questions. Why do I do left main stenting? How do I do it? And do I use upfront 2 stents or do I still do provisional stenting? I would say that why I do it, it's probably like many of you, it's just because Andreas GRUNTZIG was already doing it. And I have to remind you that it has been published that with much less tools than we have now in 20, he was doing his 3rd case ever. It was a left main stenting, and yet only a balloon for this. And it was reported as successful, but we have to pay attention to finally the sudden deaths of this patient about 4 months after these procedures. And I think that this is the main issue to be discussed. It's not because it's an easy to do lesion. If you think about this, there is no tortuosity. It is the very first part of a very large vessel. Of course, it's going to be easy, but we should do it only if there is a good discussion between us, our colleague surgeons. And I think that it's very important to put back the things and the data in perspective. You surely have heard about all the buzz around the study Excel, with some reporters on the BBC going live and showing some issues with the analysis of the data. And this was so strong and was supported by actually a very angry surgeon who was initially a part of the study, that finally the whole guidelines on left main stenting that were published, the Society of Surgeons just denied after the participation, and that this is the same indication to do surgery or to put a stent in the left main. There is an ongoing controversy, and it is not going to be stopped, but we have to look just at the data and analyze these with the best knowledge on statistics, the best clinical background also. So, of course, we have to talk about the Excel study that was presented with the 5 years follow-up by Greg Stone at TCT 2019. What did happen was that they were reporting finally the 5 years outcome of what was already reported at 3 years, like a non-inferiority between left main stenting and surgery for patients having a significant left main, more than 70% diameter stenosis, or with an IVUS that was proved to be significant in many studies when your minimal cross-sectional area is less than 6 millimeters square, or with a significant FFR. Of course, those were not the most difficult patients that we know are recommended from the syntax studies and others that should have surgery, if possible, with the high syntax score. And of course, those patients were excluded if they could not be under double antiplatelet therapy, there were some other lesion. The data have been published, but at the last moment, the main surgeon retracted his view because he did not accept the results of this randomization. It is nearly 1,000 patients in the CBG arm and the PCI, and you know that that was done with the Abbott Science stent, and the primary outcome was the follow-up at 3 years. We have an idea here of a very good follow-up with more than 90% of the patients followed up to 5 years. But if we look at the results that were sparking all the problems, this is the raw data curve. And if we look at the CABG, we know that the outcome where you have a combined endpoint of mortality, stroke, or myocardial infarction was in favor of stenting the left main, but with time, we saw that at 3 years, the results were the same, but after, this is the trend that is rather worrisome. The conclusion that you can put on this curve is simply that there is no inferiority, and this is the same. You can look at the results differently, and you can indeed see that on the very first year, of course, surgeons were having more myocardial infarction, but it has been discussed, this issue has been addressed, that maybe the definition of the MI in the Excel protocol was not following the latest recommendation. You always have more troponin and you always have more CK release because of the surgery. Between the first year and the second year, not much is happening, but look, after 12 months, those curves are starting to diverge, and they are diverging, and it is not in favor of stenting. If you look what is happening between 12 and 60 months, you have a worrisome divergence between the two curves. So you can interpret the data as it's the same, or you may ask yourself what will happen to my patients in 7 years or in 10 years from now. Is it going to finally stop? I think that it is the reason why there was some criticism in this conclusion where it was finally decided to say it is the same to put a stent or to do CABG to up to 5 years to left main patients. This led to the recommendation that we know we are not talking about the triple vessel disease, we are talking about the left main. In a left main with a high syntax score, there is no doubt. You arm the patient if you start to do PCI. If the patient is eligible for CABG, we are still going to see some of these patients who will refuse the surgery, and we will still have to do something to them. But the surgeon don't like this conclusion where it is a class 1A for PCI and for CABG if we have left main disease and a low syntax score. I can understand them. We have difficult patients, and we know that if we are addressing finally multivessels or left main stenting, left main, we see that for a high syntax score, CABG will be better, but in this subgroup, we could accept the option of doing a left main stenting. We know that the difference is more marked, and already with a syntax score of 23 to 32, there will be some difference. But not all patients are the same. I know that in Riyadh you have a lot of diabetic patients. For example, we have reported and published this with Dr. Lawand in the time, the importance of the disease in the coronary arteries with diabetes is incredible. So that finally those patients are for sure not recommended with multivessel disease, and still we sometimes have to do it, but we have the same trend, although not significant, for left main stenting. Good news, there was some increase in mortality, and they put together, finally, all the data. They put together the novel studies, the pre-combat, the syntax, and all together they came to the conclusion by this analysis, meta-analysis, that the risk of finally cardiovascular death was not increased. But this analysis is done by, again, some that are bound to the industry. When you put those data in the hands of statisticians, they will come up with some time results. And I think it is, if we are looking at this report from JAMA, which is a more important journal than just American Heart Journal, that is this meta-analysis reported that I show you just out of State in Press, they were reviewing other tools to assess the results of these randomized control trials, and they went to PubMed. They were looking at the different randomized trials, but every time that you do a trial, you can use just the trial, but you can also use a priori knowledge based on what has been done and published before. And those are based on interpretation, where finally you come up with observations that are rather worrisome, I would say. If just you are using the same definition, not yet this Bayesian interpretation, but you are still doing the statistical analysis of the results at 5 years of the Excel trial, you would actually not be able to keep the conclusion of the article in the New England. But more importantly, and you have to know this, if you take all the patients together and you do this other analysis, you will come up with data that gives you the impression, but that is confirmed, and that is 99% for sure, not 100%, that there is some excess in mortality. And you can see that you will also have nearly 90% be sure that there was a difference in the outcome of the patients treated by PCI compared by CABG. So by simply looking at the curve, you have the impression that there is a divergence. If you want to be nice with the data, if it is your own study, and finally you are a bit too enthusiastic about this, you will try to come up to, no, it's still not inferior. If you put the same results in the hands of independent statisticians, they will come up with then the possibility to look at what was happening in different kind of studies using the prior knowledge or not of these studies. And finally, there is kind of a very interesting summary here of the different trials. You see that in pre-combat, there were not so many patients, but this is where you have 300 patients in each arm. You have the Noble study. We know that it was not showing non-inferiority, but it was in favor of surgery. You have the syntax. You have the Excel, that was the largest that was done. But finally, what is happening here is a very interesting conclusion that you can perhaps be confused by your results. You can perhaps, and it's worrisome, but if you see what was happening in the recent COVID period with some articles that were also taken out of the New England or the Lancet, sometime, if you go back to some statistical analysis, you may have to sometime retract some papers. I don't say that the Excel trial should be retracted, but this independent analysis was stressing the point that when you have so many co-investigators involved with the companies, and that we have nearly $900 and more $1,000 involved in the people doing the analysis, you might have some bias in being over enthusiastic in interpreting the data. But that was some introduction about should we do it, but once we are with a patient where we should do it, finally, is it a difficult thing? I would say that if you look at the size of these arteries, and you know that by analysis, those are large vessels, they are easily addressed by your very first wiring procedure, it's simply a good bifurcation. And it's just something where you have to pay attention, and you have to remember Finesse laws that if you have on one side 3.5 millimeters, you have on the other side 4 millimeters, you will have to apply this, and you will come up with a proximal segment that is for sure 5 millimeters. If on the other side you have 2/3 of, if you applied Finesse, an LED proximal 4 millimeter, circ proximal 3.5, 2/3 of 7.5, that will be indeed 5 millimeters. So you will need stents, and you will need to know your stents. And you have some data out there that are quite interesting, where you are just with the possibility to open your stents and see an overstretch. What is happening to the cell opening? What is happening to finally the structure? When are you going to break it? Those are very interesting updated data published, where finally they were showing this previously a couple of years ago, but they were showing it with the newer generation of stents that we have. And you must know that you have, for example, for the Onyx, you have an extra large, you have a large one, you have the same for the O0 or the Synergy. You have very interesting stents for left main stenting, where those extra large model can go quite high. But what is interesting is the possibility to not take initially, of course, you should not size the proximal vessel, so the left main, and put that 5 millimeters stent into the bifurcation, because then you are going to have plaque shift. Of course, you have to decide the size of the stent for the side branch, and the proximal LED would be 4 millimeter of 3.5, and you need to be able to do the POT procedure to have the proximal dilatation. So in this condition, it is a simple bifurcation to do, but you need to know your stents, and you have tables where you can find that some will be better. The extra large Onyx, for example, will offer you a very large access to the side branch, will offer you a very good overexpansion. You need also stents that are able to be seen, because you are going to do some procedures, and not all stents are created equal. Of course, some of them are very good to go to challenging lesions that are quite distal with very thin layers. But I would say that for left main, you don't need this. You rather need some good support and some thick structure that are going to stand the mechanical force, and that you also need to see. So this is important for the procedures. And so the left main is just an easy, sometimes not so easy lesion bifurcation, and you need some cheap experience. If we look at a recent pool analysis of what has been happening in the registry in the United States, we see that some operators are never doing any left main stenting. You see that here, the majority of the left main procedures were done by just a few, and this is the same. Some sites are never doing left main stenting. We are in Belgium with some centers without surgery, like the place where I am working in Ambroise Paré. we still do left main stenting. We are not perhaps going to do very fancy, difficult left main procedures where we need ECMO, because we don't have a surgeon to do ECMO. Then I will go to another site where it will be possible. But please pay attention that it looks like just a bifurcation, but it can be sometimes a pretty complicated one. And in this registry, you see that in 1/4 of the patient, there was some mechanical circulatory support used. I think that this is more often in the US than what we will ever do in Belgium or in Europe, because we don't have a reimbursement for this. But for the rest, I would say that finally, it is important, if you are committed to do left main stenting, to well do the assessment of the lesion before, to characterize correctly the lesion, and to decide if you have the physiology, if you have the morphology that you have to do it. And post-intervention, you will want to leave a result as good as possible. It means that you will have to assess the results of your stenting. We have many tools. We have IVUS. OCT, I would say, is less adequate for the left main. You have, of course, FFR, and we have plenty of data showing that the assessment of the left main is underestimated with angiography. You see the amount of plaque that you will see by histology. This is the same that you can see with intravascular ultrasound. You see huge accumulation of plaque sometimes in this left main. So it is very important to use additional tool than just your angiography to first decide if you have to do a procedure. And you see that it is safe to defer a procedure based on the FFR measurements. We are using this threshold of 0.75 or 0.8. It would be safer, but you see that in this meta-analysis with different group of patients, overall, it is very safe to defer the procedure. You can, of course, have different figures. You can have a lesion in the left main and a lesion in the LAD. You can have lesion isolated in the left main. You have to play around. You, for example, cannot have a significant left main disease if in one of the side branch, CIRC or LAD, you still have a normal FFR. You might have the issue related to having more flow because of an occlusion, but overall, the FFR is a very interesting way to assess the lesion, but you need adenosine, and you know that there is now a way to do some assessment of the lesion by looking at the diastolic curves and using the IFR of Volcano Phillips or using other diastolic index. And lately, we're presented some interesting data on the defined left main study, where they were looking at the criteria where you can defer a procedure based on the IFR value of 0.89. Below 0.89, this corresponds to ischemia. It has been compared to FFR values, and there was revascularization. You were deferral group if the IFR was above 0.89. And following these patients, you can see that indeed it is safe also to use an IFR. I must say that in Belgium, we are running a study. Peter Kayak is the principal investigator, and we are fortunate in the University of Mons to be the co-lab for the IVUS study related to this, where we will also do something similar to the defined left main study, where we will follow patients and defer based on this value of 0.89. When in my cath lab I have any doubt, I will not only rely on 0.88 or 0.91, I will just try to also use adenosine to prove the results of the IFR. But I will also, if I think that I have to do left main stenting, favor IVUS. So I always saying that we will do more procedures if we are using the IVUS, but I am also using the FFR to prove initially that I have to treat a lesion. Once I have to treat the left main, I will not do it necessarily ad hoc, but I will plan the patient so that in the second procedure, I can use imaging to define best strategy to optimize results and also to prevent some complication. If we go back to the Excel trial, we see that there was IVUS guidance in 77% of the case. Honestly, I think this is one of the best case scenario to assess indeed and to use IVUS. If you cannot use IVUS often, you see that the FFR to guide the procedure was used in less than 10%. And we know that it is very interesting. We can also use some criteria to defer the procedure, but this is much more difficult because there have been a lot of data spreading in all over the range of between 2.8 and more than 6. I would say that a lesion that is less than 6 millimeters square is most probably for left main a reason to stent, but you see that but they were perhaps assessing this in smaller Korean or Japanese patients, but these criteria sometimes are down to 4.5 millimeters square, but at least when you use these criteria, it is safe to defer the results. Now, once you have decided to do the left main stenting, that you have either the FFR or the IVUS or other criteria like IFR, or are you going to do this? But you are, of course, trying to do the best you can, and you see that it has been proven that IVUS guidance will give you a better outcome, but please pay attention. This is just not having less target lesion revascularization, but this is decreasing cardiac deaths and decreasing MACE in this kind of meta-analysis. So I think that we have also, from England, for example, a trend to see more and more imaging done during PCI of the left main, and you see that some are also trying to use some OCT, but look at this striking difference in the results. This is cumulative incidence of the patients without imaging or with imaging. There is a decrease, and this is a significantly lower MACE rate in those patients where you will have done this. This led to some recommendation to use IVUS in left main procedures and to assess the left main. What should you do with IVUS is actually you can decide to check the expansion of your stent. You can decide to look at the stent edge if there is some dissection. You can also assess the stent in both sides, and there are some easy criteria. I mean, if you can count up to 9, you will make it using IVUS. Finally, you should have at least 8 millimeters square in your left main, 7 millimeters square at the carina, 6 millimeters square in the ostium of the LAD, and 5. So it's very simple, 8, 7, 6, 5. Look, when you are getting these criteria compared to not reaching these criteria, there is a significant difference. Now, I don't say that you can do anything and everything with just an IVUS catheter. This is not the message. We know that those are CHIPS procedures and they can be sometimes very difficult. You have to be prepared if you are trying to do left main when there is a CTO together with the right coronary artery. You have to consider some ECMO support. You have to put an impeller. I will start showing you such a case after, but we have some criteria to know which patients, very bad left ventricular function, acute coronary syndrome presentation, the hemodynamics, do we have a low cardiac index? Those are finally criteria that you can use in order to just be sure that it will most probably not require any support. It should be considered, or it is. In this case, I'm not going to do the procedure in my lab. I'm just going to do the procedure eventually where there will be a surgeon, where there will be some possibility for an ECMO or something like this. Should we use 1 or 2 stents? The data are published, and you can find them already in 2017 in this comparison between decay crush and provisional stenting. More than 240 patients, they were doing full assessment, and you can see that they were doing in 1/3 of the patients some IVUS, and the results are in favor of decay crush. If you have decay crush, this is the blue curve. You can see that you have less thrombosis, you have less target vessel revascularization. It's not significant on the cardiac deaths. And still, this is something that will hold true in different subgroup analysis. Overall, it favors the use of 2 stents, and yet this is not what we are going to use systematically. To be honest, we have more data in this direction for bifurcation in general. This is what has been recently published. It's just a couple of weeks ago that, again, this meta-analysis was favoring a decay crush approach, but I think that we will not systematically, but it will be interesting to discuss on the panel, put 2 stents in all these procedures. Now, that was the case I wanted to show you. You will recognize immediately that there is an impella in place, that there is some tricky, long calcified lesion in the circ, and that there is a lesion to be addressed here. And if you want to see the image, the wire is there, and I would ask the panel, where are you going first? Are you going to treat and to wire the LAD? Are you going to try to wire the circ? It's open to the panel, but this is just a teaser. I can show you the results after, but I know that I have very good colleagues with also very interesting case that would also like to show their case. But Dr. Cordy, where would you start this case? Please put your mic on. Otherwise, I'll be blind and I will have no help in my cath lab. I need your help.
This is an ACS?
No, it's not an ACS. That's a patient has also an occluded right coronary artery and is presenting with severe angina.
Well, the thing is there is haziness even at the distal left main, and there is some haziness into the circ. So, so I think this is very tricky. But the LAD is the largest vessel. I would actually protect the LAD first before I do anything on the circ. But it seems the circ is something that you need to do if the LAD, if the RCA is occluded. The RCA is a large vessel?
The RCA was dominant RCA, yes.
Yeah. Yeah, I would still protect the LAD. It's the larger vessel, but
we have been considering this, but our problem was that if we were protecting the LAD, it was no more possible to try to do some rotablation. And these
you wanna rotablate
haziness were actually a lot of calcification that we could appreciate. So what we started to do was actually to wire the circ in order to go then with only one wire, having, and you see how tricky, it's just a bifurcation, but it's sometimes, and that's the message, a bit more than just a bifurcation. You have this remaining vessel here. If you have any occlusion, this is one of the rules, and there is a very nice talk of Jeffrey Moses on when to consider mechanical circulatory support. I had the chance, and I was fortunate to work with Jeffrey Moses in New York for a couple of years, so when I was running the core up there in New York. But if by any chance you can get an occlusion, if you don't have the impella, you are going to lose the patient. But with this, actually, we could process and get a pretty decent result in the circ. We took a large burr after, and we start to have a better flow in this circ by wiring directly and considering the LAD and doing provisional stenting. In this case, of course, we would be doomed to a failure. And you see that we are improving the situation with a larger burr, and we will then proceed to wiring the LAD, and then we will go for a DK crush procedure. I will perhaps go directly to perhaps some advanced procedure where I can share with you here the procedure where we could, of course, and we are at the end of the DK crush that we were following step by step. I, of course, will not go through the details of these procedures, but you can appreciate now that the patient is very much stable. We do a POT after the kissing balloon inflation, and this is the results that we were getting with a patient perfectly stable. And this is a way to do left main stenting. Of course, I don't hide it. We did some IVUS, and the results of the IVUS are summarized in these slides, where you can see that we have perfect apposition, and we are reaching 22 millimeters square in this left main. We are asked to be at least with these criteria. So we can assess the distal LAD, we can assess just at the carina. This is the aspect of the carina. You can recognize the circ wire here. You can see that at the carina, we had 10 millimeters square, so we were well above the 7 millimeters square, but this is the whole trick. First, you have to decide, should I do it? And you cannot decide it alone. There will still be a lot of patients, I think, where you have to discuss if a CABG would not be an alternative. The meaning of this presentation was not to say we can do everything and we should always do anything and everything. I show you some results. There are some concerns about the statistics in even the Excel trial. You have to be careful. You have to present to the patients the two alternatives. And of course, there will still be patients where you cannot actually do any CABG, and you will have to then do very tricky procedures, sometimes easier with only one stent. If there is any question at this stage, I can try to answer them.
I think for the sake of time, Stefan, I would like to thank you for your presentation and nice case that you shared and nice demonstration of how we think about left main intervention. We have two cases that we want to present, then we're going to open the discussion and the questions. So anybody that has question, I think you should send it on the question and answers or to the host, and we'll be reviewing these questions and answering these questions and giving it to the panelists. We're going to move to the first presentation by Dr. Ali Al-Abdali. He's a consultant internal medicine cardiologist, head of cardiac science department in Al-Hada Armed Force Hospital in Saudi Arabia, Taif. He's going to present to us a high-risk PCI post-TAVR patient. So Dr. Ali, please, could you start your presentation? Dr. Ali?
Unmute, please.
ترفع صوتك يا دكتور علي. We cannot hear you very well. We need you to, we can't hear your voice.
Yes, you see my slide?
Yeah, we see your slide. You can put it on presentation. You can put it on presentation, okay. Absolutely. And now we can hear you better. You can start now. Thank you.
Okay. First of all, I'm grateful and thankful for the organizing committee to have me here at this webinar. Our case presentation today, she's a 37 years old obese female patient. She presented to our emergency department complaining of chest pain for the duration for 1 day duration. This chest pain was worsened in the couple of hours, and her medical history included hypertension, diabetes, and osteoarthritis of both knees with limited mobility. She has ischemic heart disease, known case of ischemic heart disease, status post PCI to left main LED and LCX, with total 5 drug-eluting stents in June 2019. Then she had an staging PCI to the RCA with 1 drug-eluting stent in July 2019. At the same session, she underwent the transcutaneous aortic valve replacement with the core valve, size 26. So at her presentation and the admission, her blood pressure, the pulse rate, and the oxygen saturation were within normal limits. She had the normal heart sound and an S4 heard on the apex, and she had a clear chest and no signs of heart failure. Routine blood tests demonstrate high sensitive troponin of 50,000. And she has her renal function test. It was within normal limit, and the electrolytes also. The chest X-ray for her, she had no congestion, no sign of failure. This is her ECG, which shows the sinus rhythm LVH, and compared to her prior discharge ECG, there was new T-wave inversion here in the inferior lead, and also she had a dynamic ST changes during this presentation. Her echocardiography done at the emergency department shows normal left ventricle systolic function. The calculated ejection fraction by the symptom method was 60, and the left and with a positive regional wall motion abnormality, mainly in the inferior and in the apical region. In addition, it revealed adequately functioning prosthetic aortic valve with normal right ventricle systolic function and dilation. So patient diagnosis was a non-ST elevation MI, and due to her severe chest pain, she was transferred to the cath lab for early invasive coronary angiography. So this is her coronary angiography. This is the LAO, and for the right coronary artery. And it shows in-stent stenosis in the mid-RCA, and it's a severe stenosis. This is the other view showing the same lesion here in stent stenosis. This is the injection for the left system. And here show an ostial and distal left main lesion. Also LCX lesion show dominant here also can be seen, ostial and mid LCX lesion. So, and this is the spider showing more, this is the lesion in the LCX. And this is the LED lesion here. Ostial LED lesion. So for this patient, now she presented, she's a known case of post status of TAVR, and she now presented with non-ST elevation myocardial infarction, and we had this result of the diagnostic coronary angiography. So what to do with the next? Shall we call the cardiac surgeon and to be assessed for a CABG? Shall we label here to do a complete high-risk procedure for intervention for the left main and the right coronary, as well as the CIRC and the LED, or to continue with medical therapy? And if she labeled for a PCI, should we put a supportive device or no? So this is my question, our questions during after the diagnostic coronary angiography. After that, we proceeded to the we called the cardiac surgeon. The discussion and the patient was on the table, and the consensus was to continue for a PCI strategy because due to her overweight, she's high, and the high level of the troponin, she's not a candidate for an emergency coverage. So we proceed for her with an intervention. We started first from the right coronary artery. We did multiple balloon in the right coronary artery. Then we finished with the drug-eluting balloon, and it inflated to nominal. How can I start? And this is the right coronary artery, post ballonic PTCA and post drug-eluting balloon also. This is without the wire, and we see here the result. It's excellent result here. Then we shifted to the left system, and we started with balloon.
When you were doing the dilatation, you were doing very high pressure. Do you think that there was initially some under expansion? And that was the reason for this focal racinosis in the right?
The focal stenosis in the right, it wasn't, it's not come to our thought that this is an under expansion of the brief stent in the RCA. And what this is a new lesion. We went with an NC balloon, and so we dilated twice, and we saw that it is an excellent result with no stenosis left. So after that, we went to the drug-eluting balloon. Is there any question?
No, keep going. Finish your presentation.
Okay. So we went to the left system. Then in the left system, we started first with the left main, and we started with the balloon in the left main covering the ostial and the distal left main. It was inflated to the high pressure. Then we did with inflated balloon in the proximal LED. We inflated balloon in the proximal LED. Then we went with the drug-eluting balloon in the LED. After that, we see that the result here, the ostium and the distal of the left main is intact. Is the stenosis will successfully treated with the balloon. Then we went to the circ, the mid circ here. We dilated with balloon. Then we went to drug-eluting balloon. This is the result after the dilatation. This is again the result here. This picture we see here, the ostium and the distal of the left main, also the LAD is intact. This is another view also. And this is here. And this is here the final result.
Okay. So I think, Dr. Ali, we will actually keep you with us, and we're going to come back and discuss the case. We want to go through the two cases, and then we want to open it for the discussion with the questions. And for the sake of time, I think it's important. But anybody who has any notes and any questions, please write them down. So when we come back, we can discuss with Dr. Ali what's our thoughts. Definitely, there's lots of questions here about the case, and we have received already a good number of questions from the audience as well. So we're going to come back and ask the panelists and contribute. So I would like to thank you for showing this case, which is an interesting case, but we will come back to you and ask you more questions. We were going to proceed with Dr. Kazem, who's an interventional cardiologist from Al-Hada as well, who's actually going to show us high-risk PCI of left main as well. So Dr. Kazem, if you show your case, please, and then we move to discussions with the panelists. Dr. Kazem, Hamidullah.
Yeah, I'm here. Yeah, can you hear me?
Yes, yes.
About the slide is okay?
Yes.
Assalamu alaikum. Good evening, everybody. Thanks for inviting me on this webinar. My case is 59 years old male, presented to the emergency room with typical chest pain of 1 day duration, which worsened in the past couple of hours. He had a history of coronary artery disease. We cast him 3 months prior to coming to our ER, and he had multivessel disease, and we referred the patient for cabbage. And the patient refused the risk of surgery and went home against medical advice. And he's known history. He has other medical history of hypertension, diabetes, chronic obstructive pulmonary disease, and peripheral vascular disease with right bed 2 amputation. And he denied any family history of coronary artery disease. As admission, his blood pressure, pulse rate, and peripheral saturation were 135/78 and 100 beats per minute, the heart rate, and 98% saturation on the room air. On physical examination, he had no signs of congestive heart failure. Routine blood tests demonstrated normal renal function and elevated troponin. And chest X-ray revealed no signs of heart failure. This is the ECG, which reveals sinus rhythm with slight AC depression and anterior pericardial lead with a high intensity of upright T wave. The echo revealed reduced LV function with ejection fraction of 40% with a regional wall motion abnormality in the forms of hyperkinetic epic and anterior wall. In addition, it revealed mild mitral regurgitation with normal right ventricular systolic function and dimension. So a patient was transferred to the cath lab and for the early invasive coronary angio was done and showed multivessel disease, including distal left main and ostial LAD. This is the angio. This is the right RCA. And this is the left system. The RC is occluded, CTO, cutting retrogradely from the left system. And the distal left main has tight lesion with ostial LAD and RCA. And even the ramus is tight lesion. This is the next view, showing there is a proximal LAD tight lesion, and the RCA is filling. The distal left main is tight from this view also. This is a spider view. Again, it demonstrates the trifurcation tight lesion. So this is another view. So what we have to do for this patient, and actually, again, we consulted the cardiac surgeon regarding this patient, but the patient was not accepting the surgery because of the multiple comorbid condition, and the surgery gave him the very high risk. So we decided to go for PCI. So first of all, we went for the right coronary, the CPO. We used the this is the wire after crossing the. We used the first sign blue, but it didn't go, and we tried with the pilot with microcatheter, and then pre-dilatation with 2 millimeter of balloon. Then we went with stenting of the vessel. This is distal stenting. Then this is the mid, and this is the proximal. We went distally because of the small vessel. We went 2.5 millimeters, then 2.75, and finally 3 millimeter stent with post dilatation. Distally 2.75 balloon NC, and proximally went 3.25. This is the final result for the right. Actually, the distally diffuses these. The acceptable result. And then we went to the left. The left, we did wiring, 3 wires. We put in the LED and the circ and the ramus. We pre-dilated the LED and then the left main with 3 millimeter balloon, and we stented the LED from the proximal side with 3 millimeter. Then we went to the LED to the left main with the 3.5 millimeter stent, and then we did the part with 4 millimeter in the left main. We rewired the circ and we put balloon in the circ 2 millimeter, 2 into 15, and the 3.5 in the left main to LED. We kissing done. Then this is the result after the kissing. In the beginning, I didn't want to stent the circ, but actually over here, it looks very tight for me, the ostia. So I had to put another stent in the small stent, 2.5 into 9 millimeter in the stent with then at the ostium of the circ, and then we did kissing, then again caught. This is the LED up to. This is the final result. I think we followed this patient after 3 months recently, and his ejection fraction improved, and he was symptomatic, and he was in good condition. Thank you very much.
Thank you very much, Dr. Kazim. Yeah, we will come back to you with some questions. I'm going to actually direct some questions to the panelists and to Dr. Stefan. Dr. Stefan will go to the first case, which was an intervention post TAVR, and the question here: if this patient need hemodynamic support, which device would you choose in such patient?
The question.
Dr. Stefan?
So I am not aware of the safety of the impeller through TAVI. So I personally don't have an experience of doing something like this. So in this case, it might be safer to ask the surgeon for ECMO approach. I don't know what the other colleagues are thinking, but that's
Dr. Mutari?
A very good question. Is it safe to go to valve? I'm not sure.
Yeah. What do you think, Mohammed?
I agree with Stefan that probably the best hemodynamic support for this patient post-TAVR is to put an ECMO. You don't want to go. I mean, first of all, the patient, in this case, the patient did not need hemodynamic support. I mean, with the normal ejection fraction. But the question is an excellent question. In case you need hemodynamic support, I think the safest is to stay away from the TAVR, you know, and put an ECMO.
Even the age of the TAVR doesn't matter. If it is an older few years, do you think this is maybe more stable, and you can cross it with the Embella catheter with no problem and wouldn't affect it? I mean, the Embella is a very nice device, and it's not a malignant.
But it's a bulky device still. I mean, it's not.
It goes through the wire, so it's actually a very nice, smooth device if you put it. But I don't know. I think I haven't really done it through a valve, but I would think why not? If the valve is not new and it's old, and maybe, I don't know. What do you think?
I think there are two concerns. Number one, in the early implants, you worry about mobilization before complete endothelialization. This is a bulky device, a bulky valve. And the device, the motor, you know, while it's crossing, I think it's also of the impeller, it's huge as well. But the other risk is, you know, with all the data we read about early thrombosis of the leaflets, you wonder about impinging it throughout the procedure for 1 hour or so while you do the left main, or 2 hours. You know, you might predispose patient for thrombosis of one of the cusps of the leaflets following the procedure. And to be honest, there are no studies that I'm aware of about the safety of the Impella, but we could use safely percutaneous CPS, those small ECMO devices, you know, not the full ECMO machine, which are available in few cath labs, and you do small percutaneous, venous and arterial. You don't need a full surgeon and cut down to do it, which in this particular case, I don't see really a reason for circulatory support.
Absolutely, absolutely.
Yeah.
This is a more of a normal EF, and patient valve is functioning well, so it should go well. And it's an in-stent restenosis, which is actually an easier procedure than any other procedure because everything is covered and you're working within a metal jacket. So it's very easy to do the procedure. So it's, Stefan, you're talking about imaging in this case and how important is imaging, especially in in-stent restenosis. I think IVUS is an essential component of any procedures related to a major in-stent restenosis, especially if you see it in a focal lesion, then you really want to know why in this particular area that there is in-stent restenosis. Could you shed more light on this for us, please?
So the reason that you have to do imaging, if you cannot afford to do it in all your procedures, you have to choose the right moment. And it's really left main stenting, and it's to understand a failure. And a failure can be a stent thrombosis or it can be a restenosis. You have to understand if there was any kind of stent fracture, for example. We published some case of at the time the Cypher stent was not able to expand high enough to cover a large right coronary artery, and at an inch point you can have sometime a fracture of the stent. That was one of the mechanisms. If you are missing some struts, you can easily understand what is happening and you can put a new short stent there. If you see that the stent is under deployed and it will not always be very well seen on an angiogram, there can be some ring and some under expansion caused by some circular calcium. If you recognize this, that was the reason I was asking. You need to go with very high pressure balloon. You have OPN balloon that can go up to 35, 40 atmosphere. We now have the lithotripsy. We have the shockwave in our lab. Even after stenting, we can use it if there is no good expansion. And surely if the patient is coming back with restenosis, we have to understand the mechanism. Is it a failure because of the drug that was not correctly finally working, or is it just a mechanical issue? And that's really imaging. And for this, I like a lot IVUS, but I must be honest, OCT will give you even better pictures. If you are not dealing with an ostial right coronary artery with a left main, you need to flush. So the resolution of your OCT will be even better to understand what is happening to the struts. And there was another question in the panel there. The questions about bioresorbable stents for a left main. I think that we don't have enough data to support now the use of BRS in such lesion. In left main, we are now working a lot with the McMurray stent from Biotronic. We use it in proximal LED. We use it in bifurcation sometimes, but not to do tricky decay crush. But we will not use it in a left main because we cannot overexpand enough. And so we know that we will have also there a mechanical issue. If we try to overexpand a 3.5 McMurray's to a 5 millimeter, it's just going to break.
Yeah, so, I think the VRS, we were burned badly by the experiences before, so we rethink twice before using any biodegradable stents, especially in the major vessels. Muhammad Tayari, regarding the intervention strategy that Dr. Ali did, he started with the right, and he had a very tight ostial left main. Any concern about this strategy? Do you think this was the right strategy? Would you do things differently?
No, I would not do. I mean, the right, just it's a focal lesion, you know, it can be done easily. And you have to understand also, you know, cannulating coronaries after TAVR is not an easy procedure. Okay, you have to, you know, have skills in doing that, and I congratulate Ali in doing that. The only thing that I'm also supporting Dr. Stefan about imaging, especially if you have an stent stenosis of an ostial left main. You want to make, and you are not using another stent. I mean, he used only drug-eluting balloon in this case. So you want to make sure that you are really, your ostial left main is covered by struts, you know, from the initial procedure. And I think it's difficult with the fluoro only to see the struts of the stent when you have a TAVR. You know, I think imaging in this case is mandatory to see your stent, see the expansion of the stent, see how much you're back into the aorta, you know, covering the ostial left main, and then you can dilate it and decide about stenting or just drug-eluting balloon. The other thing, also what was done nicely in this procedure, that, you know, the surgeon was consulted, and this brings the importance of a heart team, you know, whether for emergencies or, you know, elective PCI of left main. I mean, you have always to discuss the case with a heart team. We've seen from all the randomized trials that Stephen showed nicely that PCI of left main compared to CABG is not inferior in low risk and intermediate risk center score, but you always have to include the discussion within a heart team to choose the best option for the patient.
So would you think from the get-go to refer this patient to surgery?
You mean the first one, the TAVR patient?
Yeah, yeah.
No, I would not send him to a surgeon, you know, because he already, you know, chose his path initially with the TAVR and the PCI. But having a surgeon always, you know, included in your discussion, give you also a support to you if things go, you know, unwell.
Yeah, I totally echo you. I think if there is a case that intracoronary imaging is indicated, then this is the one, because really imaging on this case is very instrumental on the decision. The other thing I will ask you, Mohammed, Dr. Qutb, about the drug-coated balloon, the left main. I'm not sure about the data and how strong is the data for drug-coated balloon, the left main. I'm
not aware of any. I didn't come across recently drug-coated balloon.
Very comfortable just using drug-coated balloon in the left main. I would still use a stent if I have to.
I agree, yeah. I mean, to be honest, this patient already failed 6 stents within 1 year. And no heavily calcified diffuse syntax score, definitely more than 32 without calculating, but it's very high syntax score from the beginning. And imaging after she failed all vessels, right, left main, ostial circ, mid-LAD, all came with ISR, especially at the areas of overlap, and some areas were calcified, as Dr. Stefan mentioned. It was very hard. Was it hard during implantation, like inflation with NC balloons? I don't feel comfortable with drug-coated balloon alone, because I don't think it's an issue with drug here or medication. It's not, I think it's more something mechanical with the stent itself. Either, most likely it's under expansion, just from looking at the nature of the diffuse calcified coronary disease she has. I mean, malapposition or late malapposition, I think it's too early, and I'm not sure what types of stent they used in this stent, but I think it's all mechanical due to under-expansion, due to calcification, and it may be doing cutting balloons, coring balloons, or shockwave, giving though the difficulty with cannulating through a TAVR. This is absolutely difficult. We're talking about even normal cases would be challenging to go through a stent with the bulky shockwave or the, you know, the other types of cutting balloons. But I think this is the better way to go, and making sure it's well expanded this time. And I don't think it's wrong to consult surgery here. It's a must. And because I'm just concerned, 6 stents, and she came back within 1 year. So, but I know that she already went through a TAVR and things, so it's better to continue with PCI at this stage.
Dr. Ali, I would like to thank you to share this case. It's a nice case, and thank you very much for showing it to us and sharing it and initiating this very interesting discussion. I think we'll go to the next case for the sake of time, and we'll try to go. Dr. Stefan, about the strategy of the next case, would you have done anything different?
I think I would not start with the CTO, to be honest. I would start with the left main. Right. But I would do the same kind of provisional stenting approach. There was also kind of a large intermediate branch. So if you committed to 2 stents immediately, even if, and I agree, there are some data out there that are recommending statistically perhaps to use two stents, we still have to look, or the osteum might be a disease, or we can manage to use only 1. I was wondering, at the end of the procedure, there was an additional stent put in the osteum of the circ. Was it a kind of a tap procedure? There was nothing that was crushed inside the left main, if I understood well.
Yeah. As well as there was no imaging here, so I don't know. I think imaging was also important on the decision making.
Yeah, we did the imaging. The IVUS has been done, and it will affect these stents. Yeah.
Oh, great.
And we did the part of, as I said, after putting the stent, and we crossed the circ ostial, and we did the kissing. With the kissing, we found that the ostial circ was really tight, so we put a small stent with a tap technique, and we put, again we did the kissing, and we did the report, and we imaged that with the IVUS. It was well appropriate.
Mohammed Ntari,
Yes.
Dr. Ntari, what do you think of going with the 2 stent strategy versus 1 stent strategy? Do you think the 1 stent strategy, as Dr. Greg Stone tweeted 2 days ago or last week, that the 1 stent strategy has to be put in peace, and we have to go with the 2 stent strategy from now on? What do you think of that statement?
I think this statement is not correct for all, anatomies, because it depends on the, the lesion that you have, classification of lesion. Where is the, the disease? Is it continuing to the ostial LAD, ostial circ? That's one thing. Also, the size of the, side branch. If we consider the circ as a side branch, the size of the side branch. This is also, you treat your left main, as what I do. I treat my left main as any other bifurcation. I choose provisional stenting when I think the side branch, in that case, if it's the circ, does not need a stent. And then, you reevaluate during the procedure, okay, with imaging, with the physiology, IFR or FFR. Then you can decide if you have to do 2 stents or not, and then you can use many of the ways to use 2 stents. But if you want to use 2 stents from the beginning, I favor DK crush.
Yeah. I think the reason why Dr. Stone was talking after the release of the definition 2 and showing that the DK crush 2 stent is way superior than the provisional stenting on all distal left main, all comers that he actually showed in his paper. Dr. Kutub, any comment?
No, I think there is still a role for provisional stenting. Depends on the acuity of the case, of course, and the angle of the circ. If it's free, the ostium of the circ is free of disease, or very mild disease and a 90-degree angle or almost, I think I wouldn't, but if it's already both, the Medina is 111 with severe tight lesions, I think it's better to we start with DK crush rather than having to do TAP eventually or things, but just from the beginning. But in this case, I'm not disagreeing with what they did, but I'm just saying for the longer outcomes, having few struts hanging in the left main from the TAP probably will be less, even statistically, inferior than double DK crush that is done properly from the beginning. It's easier for the operator, better for the patient to plan it ahead of time. But if there is a straightforward distal left main into LAD, circ, very mild disease at 90-degree angle or about, I think a provisional is the way to go here.
Stefan, do you think that it's DK crush and everything is out for the left main bifurcation?
No, I've seen a very interesting approach. It was in your intervention two months ago. This is Gabotos presenting this work on a revamp culotte, where you are also going to do a double kissing in a good old culotte procedures. And we have been studying culotte for quite many years with Sarah's organizing some study with guidance in the time. And so there have been bumps on the road for every procedures. And the most important is to go to the bench and do some visualization and using those micro CT, using those direct visualization in plexiglass to understand what is happening. And that was really interesting publication from Gabotos, showing that if you do basically the same as a double kissing in the DK crush, if you do it with your culotte, you will get actually a procedure that is faster with a better opening of the stents, and they were doing also some micro CT to show this. So
Stefan, I think we lost you here.
I will do in culotte.
Stefan, I think we lost your last sentence. I haven't heard it myself. Hello? I think we're having internet want to end the session.
Well, what do you think, Dr. Kurdi, about the culotte technique, though? It's a beautiful technique, but it always shows inferiority in clinical trials.
Yeah, I think this is what Stefan was talking about. I think Stefan, we lost you for a couple of minutes.
I'm sorry.
It's okay, but we were saying as you were discussing that with the culotte technique, I think the main reason that it's getting out of favor is the deformity of the ostium of the side branch and how you cause deformity within the proximal part of the stent. And this is why I think the DK crush, I don't know about this double kissing culotte, but I think optimization with proper imaging is very important and essential. And anything, I think the take-home message I would say from the left main intervention is that left main intervention is still a very valid procedure. It's not only left main is not only surgical. I think all the intermediate and low risk syntax left main should be approached by the interventionist. Patient choice and patient involvement in the discussion is important, but not within the cath lab, of course. As you take the patient out and you show him all the facts and the pros and cons of surgery, being very transparent and honest, what are the real differences between surgery and PCI, and indicating that in the low and intermediate is actually the way to go. it is actually possible that PCI as good as cabbage. I think choosing the indication is very important, but as well as choosing the technique is very important, and preparing your lab and your team, especially when there is a possibility that you may use any hemodynamic support device. I think that's very important, that you have the device that you're most familiar with, and the device that you feel comfortable with, and the device that your team is actually familiar, because you're not going to do it by yourself. You have the team around you who's actually going to run it. They're going to take the patient to the CCU, and you don't want any complications. So you want the team to be very familiar with the device that you're using. Such as the TAVI cases where we don't know which device, I think that's also complicated. But it's definitely there was no indication to use a hemodynamic in this particular case. I think using 2 stent or 1 stent, I think the notion is moving toward 2 stents now more before than provisional stenting. The provisional stenting was the data that we were actually holding, but I see in the last 3 to 4 years that the DK crush has gained huge popularity and supported by a good number of data, especially the latest, which is definition 2 that published in the European journal just last week, very supportive of the DK crush with a significant difference versus provisional stenting. So I think we're going to learn. It's a field that we're learning every day, and we're going to learn more what's to be the best technique to do the left main. But left main is something that's still a challenge that we're still facing, and we're still doing webinar. This is why we're doing the webinar today, because we think this is a topic that needs to be discussed. It's not really agreed 100% upon what to do, but what we all agree upon, that imaging on left main is essential. IVUS or OCT, I prefer IVUS, of course, is the choice for the assessment of the left main and left main interventions, making you make sure that you actually oppose the stent well, the struts well, proximal and distal, and making sure that the sizes and the side branch, all these kind of things can be assessed by an IVUS. And if you are really using your cost-effective, then I think if you want to choose one, then IVUS is the way to go. Any final word? I don't know if Stefan is still with us.
Yes, I can try to put the camera back if the bandwidth is going well. I think you gave a very good summary of the situation, and this is an evolving field. We need more trials, we need more data, and we must stay a clinician before all, and look at the patient and discuss with the team, discuss with the surgeon, and then try to get the best results using all the available tools and imaging, of course.
Thank you very much. Dr. Muteri? You are on mute, Mohammed.
Saying that I want to thank the Gulf Intervention Society, for putting such a nice webinar, and I know that there are more to come in the near future. I'd like to thank you, Mohammed Kurdi, for nicely coordinating this session. Thank Dr. Stefan for his nice presentation, and also thank Dr. Qutb for sharing his experience. As you said nicely, now the PCI left main is coming to become more commonly used everywhere, but we have to remember that we need to discuss the case among our team first of all. Second, if we need to do it, we need to plan it very well ahead of time with the proper tools in our cath lab, and then take it from there.
Dr. Qutb?
Again, I would like to thank the Gulf Intervention Society for this great series. I'm really thrilled with it. Really, it's very nice, and I'm happy to be participating in the first one. I'd like to thank you, Dr. Stefan, Dr. Kurdi, Dr. Mutairi for their wonderful experience. I like to thank Dr. Kazem and Dr. Ali for sharing their nice cases, which are very beautifully done. And we generated very nice discussion. Nothing obviously personal, but it's very nice. And we learned a lot from it, to be honest. You summarized what the recommendations very nicely. I think preparation is nice. We need to have honest discussion with the heart team and the patient off the table about left main decisions, because it is very controversial topic still. And some, as you said, we need to decide together as a team with the patient involved about the mild cases versus severe to be able to deliver good results for the patient, long-term results. And thank you again.
Thank you. Dr. Kazem, thank you very much for sharing the case. Appreciate sharing and taking the time.
Thank you very much. Thanks.
I would like to thank you for your time and presentation and very nice talk that you gave us with a nice review of the left main imaging and decision making. I would like to thank my panelists, Dr. Mutairi from Kuwait and Dr. Qutb from Jeddah. I would like also to thank all the audience for being patient with us, for all the technical, some voice problem, but this is the internet. It's not our fault, so we do our best. I would like to thank GIS for starting this great series. This is the first one. The next one is going to be announced very soon, so keep tuned. Follow the GIS on the Twitter. You're going to have all the announcement. Follow the news and register for the coming Master Interventional Class curriculum for 2020. There'll be a lot of more topics to come, distinguished speakers, much more fun than tonight. This is just the beginning. So I would like to thank the GIS, Dr. Fawaz al-Mutairi, the president of the GIS, and I would like to thank ICOM and Medtronic for their support for this program. I wish you a great evening, and I wish this was useful. And I personally have learned, so I hope the others have learned something tonight. And stay safe, and we'll see you soon in the next webinar. And good night to Belgium, Kuwait, Jeddah, and Taif, and everybody else with us on this webinar. Have a great evening, and thank you very much. Thank you.
Thank you.
Bye-bye. Thank you.